Hello and welcome to CE Solutions. My name is Caleb Frady. I'm a full-time EMS educator and a part-time paramedic in a rural county here in North Carolina. Our topic for today is pain management in pediatric patients, and this is volume 1. At the end of this lesson, the student should be able to analyze how pediatric patients express pain during different developmental stages, formulate a pediatric pain assessment utilizing validated pediatric pain scales, explain non-pharmacological treatment of pediatric pain, and lastly, identify pharmacological treatment modalities for BLS providers. Before we can understand how to manage pediatric pain, we first need to understand how to assess and recognize a pediatric patient who's in pain. Pediatric pain is multifaceted and it includes physiological, behavioral, psychological, and developmental factors, localization of pain, or be able to get an accurate verbal report of a pediatric patient who is in pain. So our assessment has to be adjusted for the patient's developmental status. So a toddler is going to express pain a lot differently than a school-age child would, and then an adolescent is going to present and report pain much differently than both toddlers and school-age children. So we have to consider the developmental stage that our patient is in when we're assessing a pediatric patient in pain. So a working knowledge of appropriate behavior and developmental factors in our pediatric patients is necessary to accurately assess and manage pediatric pain. In addition to developmental factors and understanding that pediatric pain is multifaceted, we should also include a child's interactions with the environment as part of our assessment. This may also include some special circumstances, such as paying attention to behavioral cues from caregivers. Caregivers and parents are especially important as they can help us identify things that our patient may not be able to tell us, such as behavioral cues or behavioral changes may help us identify when the pain may have begun, how long it's been going on, and in some cases help us localize the pain just by being able to calm our patient down so we can do a better assessment. McDonald et al. Reports that 20% of pediatric transports involve patients in moderate to severe pain. And while pediatric encounters may represent a smaller share of our call volume, those encounters are likely to involve a child in pain. So understanding how different age groups express pain is important for pre-hospital providers to be able to accurately manage pediatric patients in pain. Ignoring the signs of a child in pain can interfere with our assessment and ability to provide the best possible care we can to our patients. If a child is in significant pain or anxiety, they can be inconsolable, they can be uncooperative, and our assessment becomes more difficult as we work to identify the root cause of the encounter and transport to the appropriate facility. When we're able to appropriately manage a pediatric patient in pain, we're able to improve patient comfort and improve cooperation, allowing us to do a more robust assessment and hopefully identify the root cause of the encounter. The two major categories of developmental age that's important for providers to understand, as this forms the basis of how we assess pain moving forward, is preverbal and verbal. So preverbal patients, this would include infants and very young children that typically are unable to describe their pain. And there's really no set age group for this because it all depends on the child's developmental status. Whereas you may have some kids that are 7, 8, 9 years old that have medical conditions that may make them nonverbal. That's important to consider as part of our assessment is that child's developmental status. But in this case for preverbal children, we would rely on their behavior, their interactions, things such as crying, facial expressions, and body movements to inform our assessment. In verbal patients, these are patients that can communicate, but it's not always straightforward. And we'll talk about that as we move through the lesson. Their responses and presentation of pain is influenced by their age, their fear of providers, and even their ability to understand the situation that they're in. So our preverbal patients are going to include neonates, infants, toddlers, and any other nonverbal patients. And these are some of the most challenging patients for us to assess for pain because they're not able to exactly tell us what they're feeling. They struggle to localize pain or don't understand how to yet. They can't necessarily describe the severity in simple ways that we can understand, like we would get from an adult patient. And they're typically not going to be able to give us a history of their pain, where it originated, and those types of questions that adults can give us. So the primary tool for our assessment becomes their behavior. Some of the behavior cues to look out for in preverbal neonates would include furrowed brows, eyes being squeezed shut, and expressionless, vertically open mouth. So kind of like the patient's in pain and they're almost shocked and they open their eyes real wide and just kind of freeze for a second with their mouth open. That would be a sign of pain in a neonate. Abnormal movements of the arms and legs, or even withdrawing from painful stimulus, could be included in this. Inconsolability is a big consideration for neonates and infants alike. Disturbed sleep patterns. This is likely one of those history findings that we would get from caregivers as we ask them questions about the child's behavioral changes that they may or may not have noticed. And vital sign changes, which are non-specific but are included in some of the pre-verbal pain assessment of neonates. What you see on the screen is called the FLAC scale, and we'll come back to this a little bit later and talk about it in more depth. But the FLAC scale here really just gives us a good appreciation of some of the pre-verbal cues to look for in infants and younger toddlers. Some of the ways that an infant is going to express pain could involve kicking their legs and waving their arms, arching of the body or having a rigid body, making different facial expressions, being easily irritated, not eating, not sleeping, or not being easily comforted, which is inconsolability. Infants and young toddlers can show signs of sadness or anger, and that could be a sign of pain. As the infant becomes a toddler, they start to express their pain a little bit differently than infants do. Toddlers, in some cases, are better able to localize their pain and maybe even be able to tell us what caused it. They may feel more comfortable telling this information to a caregiver, explaining what happened as one of us due to fear and anxiety. Some other things to look for preverbal children would include kicking of the legs and arms, guarding, protecting, or tugging at a limb, an ear, an eye, or body part that could be in pain, refusing a favorite toy, food, or activity, restless and being unable to sleep or get comfortable. In toddlers, acting younger, being really clingy, like a baby, could be a sign of discomfort or pain. That would include being uncooperative or showing resistance to procedures. As children continue to develop, their ability to verbally report pain improves, and this makes our assessment a little bit easier. They're able to describe where it hurts, give us some idea of severity, and explain what they're feeling. There are some considerations for school age and adolescent children when it comes to assessing pain, and the main one is to be cautious of leading questions. For example, a leading question could be, does your stomach hurt? Is it a sharp pain? What happens here is we're putting words into the child's mouth, and we may end up obtaining inaccurate assessment information. Instead, we would want to ask open ended questions whenever possible, such as, can you tell me what hurts? Or what does it feel like? Combining good question asking techniques with our behavioral and developmental assessment in pediatric patients allows us to see the full picture and fully appreciate the amount of pain that our patient may be in. By the time a child reaches adolescence, they should have some experience in dealing with pain, whether that's from injuries, illnesses, or previous medical care and experiences. Because of that, their ability to report pain is similar to that of adults. They can usually localize pain very well, describe the quality, and even rate the severity using a numeric scale that we would use on adult patients. One important consideration for adolescents is that the pain that they're reporting can be influenced by external factors. So things like previous experiences with pain, good or bad healthcare encounters can influence how they present their pain. Peer influence, not wanting to look weak in front of others, could be a factor to consider. or even depending on who's around, such as a patient or caregiver. Depending on who's around, the patient may either minimize or exaggerate their pain level depending on who is in the room. So while adolescents can report pain fairly well, it's still shaped by their previous experiences and social factors. Now that we've covered how developmental age and status can affect a patient's ability to present pain, we can start to move into our actual assessment of pain. And this assessment, especially in younger children, is going to begin with a behavioral observation. Preverbal patients aren't necessarily able to tell us what they're feeling, so what they do becomes even more important than what they actually say or tell us. That's why behavioral observation is the first part of our assessment. It should happen immediately and typically occurs the moment that we lay eyes on our patient as we're taking in all the information around us, such as how they're interacting with their environment and other factors that we may notice. All that being said, a child that can verbally or self report their pain is the gold standard, and it does hold a little bit more weight in terms of our assessment. But we should also keep in mind that our behavioral observation is used in conjunction with our patient's verbal reports of pain. As BLS providers, we should be familiar with the pediatric pain assessment. It's a rapid visual and auditory assessment tool that can be performed in seconds before we even have to actually touch our pediatric patients, and can help us appreciate, is the child sick or not sick, and help guide some of our interventions moving forward. The pediatric assessment triangle has three sides. The first one is appearance. When we're assessing appearance, we're assessing things such as mental status, tone, interactiveness, consolability, gaze, speech, or cry. So, a lot of the things that we're assessing are also some of the preverbal behavioral cues that we spoke about previously. Next, when we look at a patient's work or breathing and we assess for things such as retractions, nasal flaring, abnormal breath sounds, airway positioning, and tachypnea, right? We're asking ourselves, how hard is this child working to breathe? Some of those symptoms can clue us into pain. For circulation, we're looking at the child's skin color, looking for things such as pale skin, mottling, and cyanosis to help us appreciate the level of perfusion and possibility of shock in a pediatric patient. And our pain assessment is built into our pediatric assessment triangle. When we're looking at appearance, things like inconsolability, irritability, and altered interaction can signify pain. Symptoms such as tachypnea, guarding, or shallow respirations could also indicate pain. Shallow respirations, for example, if we have a pediatric patient with a suspected rib fracture, the shallow respirations could be due to self splinting, and that's something we can pick up on in our initial pediatric assessment using the PAT. As with adults, vital sign changes in a patient with pain are nonspecific and should be considered in the context of other assessments. So things like increased heart rate, increased respiratory rate, and changes in blood pressure, while on their own, they're nonspecific, together with other assessments and behavioral cues and developmental factors, they help create a better picture of the status of our pediatric patient who may be in pain. So we should never necessarily look at our vital signs and say that this confirms the patient is in pain. Instead, we need to apply it to the overall context of our assessment. What are we seeing behaviorally? What is the patient actually verbally reporting to us? And what does the situation suggest? So, what is the underlying mechanism of injury or nature of illness? Our pain assessment is considered a vital sign. So, just the same way that we would feel for a heart rate, assess a respiratory rate, check a blood sugar, take a blood pressure, we should also be conducting our pediatric pain assessment on any patient that has the possibility to be in pain. And when the patient's unable to self report verbally, we should use validated pediatric pain assessment scales, not only to assess their pain, but also document their pain level and any changes that arise from our management of pain. The pain assessment scale that we select largely depends on the patient's age and developmental status. The NIPS scale is best suited for neonates and preterm newborns. It can be used on patients up to 1 year old depending on their developmental status. A score of 2 to 4 indicates moderate pain that can be managed with non pharmacological treatments, while a score of greater than 5 indicates a patient that is in severe pain. And we can look at this scale and see that it includes a lot of the preverbal factors that we would look for and appreciate during our pediatric assessment triangle. We're just compiling them together at this point when we're assessing vital signs to determine the actual level of pediatric pain. So this would include things like facial grimace, cry and consolability, the patient's breathing patterns, and some of their movements between their arms and legs, and even their state of arousal, whether they're very fussy or not fussy at all. Now, I showed you the FLAC scale earlier in our presentation, and this scale is best suited for children that are 1 years old to 7 years old or still unable to self-report their pain. And like the NIPS scale, it involves the assessment of behavioral cues. The FLAC scale involves observation of our pediatric patient from anywhere between 1 and 5 minutes and rating each variable up to a score of 10. The higher the score, the more pain the pediatric patient is in. As a child becomes more verbal and able to self-report pain, as the child becomes more verbal, we can move to a more simplistic pain rating scale, such as the Wong-Baker face rating scale. The way that we would use this scale is to ask the child to select the face that reports their pain. Caregivers can help with this, but we have to be careful with leading questions or pointing to a face before the patient's been able to identify it. Our Wong-Baker scale is a validated scale that's been proven in a diverse group of patients. And it was initially designed for self-reporting of pediatric pain, post-operative care, and for patients with language barriers. A key takeaway with the Wong-Baker face scale is that we should never look at the patient's face and then subjectively assign our own pain scale to that assessment. So in other words, we wouldn't look at a patient's facial grimace and assign a 10 based off what we see. This scale is used for the patient to select the face that most closely aligns with how they're feeling, which is why it's used in preverbal patients. The last validated pain scale that I have is the visual analog scale, and this is best suited for verbal children, typically older than 7 years of age. And it adds a descriptive word over top of the numeric scale, and that can make it easier for children to kind of point to where their pain is instead of providing a number from 0 to 10, as they may not fully understand what we're asking or what we mean by that, but they may be able to look at this and say, yes, this is horrible pain, or understand that this is agonizing pain just by understanding a few common words. It can also be used to help if there is a language barrier between us and the patient, by using descriptive words that may be commonplace or even words that may be the patient's language, to help add into this to see where the patient's pain is. As we talked about earlier, parents and caregivers are able to provide extremely valuable insight into our patient's pain level. But we also need to gauge the reliability of the caregiver because their input can be influenced by previous experiences or illness with healthcare professionals, their personal perceptions of pain, anxiety or stress in the moment can influence how they report things to us. So we have to be able to critically examine what we're being told by caregivers and apply that to our actual visual and physical assessment of our pediatric patients. We also have to understand that pediatric pain is dynamic, and we should regularly assess and reassess pain and our interventions. This helps us to determine if our interventions are working, to make adjustments, optimize our pain management strategies and treatment modalities, and ensure that we're truly supporting our pediatric patient. Documentation is also crucial with pediatric pain assessment. Every pain assessment that we perform should be clearly documented within our patient care report. This would include the initial pain level, the method of assessment, whether it was self-reported or verbal assessment. If we use something like the NIPS scale or the FLAC scale, we should include that score within our documentation. It should include our reassessment findings and the patient's response to our interventions. This allows us to trend the patient's pain over time, allows us to show improvement or lack thereof, and lastly, it provides the facility with a clear picture of this patient's pre-hospital course and helps to improve their continuity of care and overall outcomes. Before we can initiate pharmacological interventions for pediatric patients in pain, it's going to be essential for us to recognize the value that non pharmaceutical treatment options have for our practice. These strategies can effectively reduce a patient's pain and anxiety levels and oftentimes serve as a bridge to medication for pain management when needed. And this is confirmed by peer-reviewed sources where Webb and Sanders in 2021 advised that alternate treatment options can significantly enhance patient comfort while preparing for or completing pharmacological therapies. So this really just highlights how BLS maneuvers are able to significantly impact a pediatric patient's pain and anxiety level. Non-pharmacological treatments are considered first-line therapies because they are safe, non-invasive, and easy to implement in the pre-hospital environment. These interventions are generally going to fall within two main categories: physical comfort measures and distracting activities. Physical comfort measures are particularly effective in younger children, so techniques such as hand holding, rocking a child back and forth to console them, or allowing the child to engage in some of their own self soothing behaviors, like thumb sucking, can significantly reduce their distress level. Providing comfort items, such as their favorite blanket or stuffed animal, also helps create a sense of security. A lot of pre hospital units across the nation will carry care pets, which is a stuffed animal within the unit for this exact purpose to help a pediatric patient who's experiencing pain and anxiety feel more comfortable in that situation. And as a result, we can manage their pain in that manner. Positioning is also a key way that we can manage pediatric pain without using pharmaceuticals, in that it allows us to position a patient in a manner that is most comfortable and least painful. This would be especially important in pediatric patients with traumatic injuries. Distraction techniques tend to be more effective in older children. The purpose of these methods are to shift the child's focus away from the painful stimulus. They would include using pacifiers, singing or being goofy with a pediatric patient, using storytelling, books, music, games, and even audio-visual devices such as our phone, or if the patient has a tablet or something like that. Really anything that can help distract the child from whatever is causing them pain. And in some cases, that may just mean be a provider being goofy and distracting and getting the child's mind off of the painful stimulus. Even small gestures such as applying a band-aid after a procedure can truly help provide a pediatric patient with some psychological reassurance and is oftentimes surprisingly effective. I found in my practice and with my son that a band-aid can fix just about any type of boo-boo. Another critical component of pediatric pain management is the presence of a parent or caregiver. Allowing the caregivers to remain with the child can significantly reduce their fear and anxiety and help us to create a calmer environment, thus improving the patient's cooperation during our assessment and subsequent pain management treatment modalities. As we've talked about through this lesson, when we're managing pediatric patients in pain, it's important that we tailor our strategies to the child's developmental stage. So, for infants, we can encourage the parent or caregiver to hold and comfort the child, utilize soothing sensory measures such as gentle touch and soft voices, pacifiers, and familiar comfort items in this age group can be effective also. For toddlers, in addition to the strategies we use for infants, toddlers, it's really important that we communicate using calm, simple, and direct language. Demonstrate procedures before performing them can help reduce fear. Even something as simple as warming up our stethoscope before we listen to lung sounds can really help the child feel more acclimated and cooperative during our assessment, especially if they're in significant amounts of pain. Distraction techniques work really well for toddlers, so using storytelling or audio-visual stimulation can be helpful. In school-age children and adolescents, these patients are going to benefit from being actively involved in their care, allowing them to ask questions and then providing clear explanations of procedures. Distraction techniques remain useful with this age group, as well as additional comfort measures such as bandaging wounds or the application of hot and cold packs to alleviate discomfort. So, to recap this slide, non pharmaceutical options are the first line and safest way to manage pediatric patients in pain, and they serve as a bridge to our pharmacological treatments. We can utilize physical comfort measures and distraction techniques to achieve those goals, and we should tailor our approach in assessment and management to the child's developmental stage. Another important component of non-pharmacological pain management in pediatric patients is the appropriate use of cold and heat therapy. These are simple interventions that can be effective, they're easy to apply in the pre-hospital setting, and can significantly reduce a patient's level of discomfort. Cold therapy is typically applied through the use of cold packs, where you have to rupture the membrane inside of the pack itself, typically shake the pack for a few seconds to activate the cooling mechanism, and it's most beneficial during the acute phase of an injury. Cooling injured areas is going to help reduce swelling and inflammation by causing localized vasoconstriction and limit the accumulation of fluid within those affected tissues. So this is going to minimize not only the tissue damage, but it's also going to provide us a level of analgesia. In Mija et al. 2024, they note that the application of cold packs is an effective first line intervention for managing pain and inflammation following acute musculoskeletal injuries. And this applies to our pediatric patients in pain as well. Now, after the acute injury phase has passed, typically after the initial inflammatory response has occurred, heat therapy becomes more appropriate. So, heat packs are going to promote vasodilation, which increases blood flow to the affected area. This is going to help enhance circulation, decrease muscle stiffness, improve tissue elasticity, and help support the overall healing process of those damaged tissues. And this is also confirmed in Mija et al., where they advise that heat therapy is particularly useful for relieving muscle tension and discomfort during the recovery phase of an injury. So, when applying these therapies in the pre hospital environment, there's several safety considerations to keep in mind. We always want to place a barrier, such as a cloth or a towel, between the hot or cold pack and the child's skin to prevent any type of injury. Limit the application of these devices to 15 to 20 minutes at a time, and frequently reassess the child's skin for any signs of irritation or temperature related injury. Keep in mind that in infants and young children, their skin is more sensitive and susceptible to burns, so we need to reassess more often. Splinting is also an effective non pharmacological intervention for pediatric patients in pain that's associated with musculoskeletal and orthopedic injuries. A splint that is properly adapted to provide maximum support is able to significantly reduce a patient's pain by minimizing movement and preventing further tissue damage. Effective immobilization not only enhances the patient comfort, but it supports overall injury management. When MS providers are considering splinting as a way to manage pediatric pain, it's important that we follow the best practices of splinting. First would be to establish a baseline of the injury. So before any splinting is performed, it's essential that we assess the injury thoroughly, evaluating for pulse, motor, and sensory function. When we assess the pulse, assess distal circulation by palpating pulses. Don't forget to evaluate skin color, temperature, and capillary refill. Motor would involve asking the patient to move fingers or toes distal to the injury. And then sensory would evaluate the patient's ability to feel light touch or differentiate sensation, again, distal to the injury. So establishing this baseline allows providers to identify pre-existing neurovascular compromise and helps us provide a comparison for reassessment after we complete the splint. Any changes noted to PMS during or after immobilization would indicate complications such as excessive pressure causing impaired circulation from the splint. Also, keep in mind that with pediatric patients, their developmental ages is important here, and our assessment isn't going to be as straightforward as it would be in an adult patient, and we would need to use some of the techniques we've previously talked about to help us work through obtaining all of this information. The second best practice is knowing when to realign or reposition an injury. Now, for long bone fractures with significant angulation, gentle realignment toward a more natural anatomical position uh, is is possible. This maneuver here can help to improve distal circulation and associated nerve function, reduce tension on surrounding tissues, decrease pain, and minimize the risk of further injury. But it should be noted that realignment is performed using gentle, steady traction, and if any resistance is encountered or the patient begins to experience increased pain from the realignment procedure, then we should stop immediately and position the extremity in the position found. In my experience, for most orthopedic injuries, splinting in the position found is the best course of treatment. However, in cases where the fracture is very severely angulated, realignment may be the most appropriate method to restore circulation and sensation. For joint injuries, such as dislocations or severe pains, the extremity should be splinted in the position found, unless your local protocols or medical control directly advises otherwise. Next is adequate padding for the splint. This is a critical but oftentimes overlooked component of effective splinting. Padding is able to enhance patient comfort. It can help distribute the pressure evenly throughout the splint, reducing the risk of pressure sores. And we know that from the moment tissue becomes compromised or hypoperfused due to increased pressure, that actually starts the clock of the development of some sort of pressure ulcer. So we want to make sure that we pad to distribute that pressure evenly throughout the splint. This would further help to prevent secondary injuries such as a sore developing, and it also improves the stability and security of the splint. So some common things that we can use as padding materials would include gauze, towels, blankets. If there's any commercial padding that's included with the splinting devices, pillows work really well for this also. And we should give special attention to padding around bony promises to help prevent skin breakdown during prolonged transports. Next, we should complete the splint. This is going to ensure full immobilization of a fracture. For splinting, the best practice is the splint must immobilize the joints above and below the site of injury. So this can help prevent accidental movement, reduce muscle spasms, minimize additional tissue damage, and can help to significantly decrease a patient's pain. So, for example, a forearm fracture should include immobilization of both the wrist and elbow, while a lower leg fracture, we would need to immobilize the ankle and the knee. After a splint is properly positioned and padded, it needs to be secured firmly but not too tightly. Typically, elastic bandages, cravats, or triangle bandages, as they're commonly referred to, can be used for this purpose. And the goal is really just to tie the whole splint together to maintain the immobilization while preserving the patient's circulation. So we don't want it to be so tight that it becomes a tourniquet. And then after securing the splint, we need to make sure that we reassess pulse, motor, and sensation, and compare that to our initial baseline findings. This is going to help us ensure that the splint has not compromised the patient's circulation or nerve function. And we should continue this reassessment at regular intervals anytime that we move the patient during transport, and if the patient begins to report increased pain, numbness, or tingling, for example. And lastly, we need to balance our splinting procedure with other pain management strategies. So, understanding that splinting is one of our non pharmaceutical ways to manage a patient's pain, and incorporating that with some of the other techniques we've learned about to manage pediatric patients' pain, such as ice application, patient positioning for comfort, utilizing caregivers to help decrease the pediatric patient's fear and anxiety so we can actually complete the splint, as well as physical touch and distraction techniques. All of this comes together during our assessment and management to treat pediatric patients in pain. For BLS providers, the utilization of pharmaceutical medications to manage a pediatric patient in pain is limited, and most protocols reserve pharmaceutical pain management for BLS providers to patients experiencing discomfort as a result of a fever. However, some of our medications are indicated for mild to moderate pain, and local protocols may allow you to administer acetaminophen or ibuprofen to pediatric patients in mild to moderate pain. So please follow your local protocols when making the decision as to whether or not one of these BLS medications is indicated for your pediatric patient. The first medication I want to talk about is acetaminophen. Acetaminophen is a common pre-hospital medication, and it's considered a non-opioid analgesic that's used for the management of pain and fever. Acetaminophen works primarily within the central nervous system to inhibit cyclooxygenase or COX. Ultimately, through this inhibition, it decreases the level of prostaglandins within the central nervous system, and prostaglandins are chemical mediators that are responsible for pain perception and the regulation of body temperature. So, by lowering the prostaglandin levels, acetaminophen is able to provide effective analgesia and antipyretic effects. It is important to note that because acetaminophen works within the central nervous system, it does not have any local anti-inflammatory effects. In the pre-hospital environment, acetaminophen can be indicated for fever in pediatric patients, and depending on local protocol, it may or may not be able to be used for pediatric patients in mild to moderate pain. Acetaminophen is considered a safe first-line pharmacological option as it's not associated with sedative and respiratory depressant effects that opioids are associated with. This medication is administered via the oral route, and the standard dose is 15 milligrams per kilogram every 4 to 6 hours as needed. It should be important that we understand what the maximum daily dose is, which is 75 milligrams per kilogram, as acetaminophen is also a common household medication that parents and caregivers may have already given their children prior to our arrival. So our assessment should include asking about any medications that caregivers have treated pediatric patients with so that we can avoid providing a patient with a dose that would place them close to the daily maximum limit. The most significant risk with acetaminophen is that it is liver toxic. And in children, this is most commonly going to be an issue if the caregiver has already administered multiple doses of this medication, or if it's an overdose scenario where the child got into acetaminophen that had been left out. But we should make sure that we ask about any existing liver conditions prior to giving this medication to our pediatric patient. Allergic reactions are fairly rare with acetaminophen. However, we should reassess continuously after administration and be prepared to treat anaphylaxis with epinephrine 1-to-1. Acetaminophen can be an effective pharmacological pain management option when combined with other non-pharmacological treatment options, such as splinting, cold therapy, and distraction techniques for our pediatric patients. The next medication a BLS provider may administer for pediatric pain is ibuprofen. Ibuprofen is a non-steroidal anti-inflammatory drug or an NSAID, and it's able to treat mild to moderate pain and fever. The mechanism of action of ibuprofen is as a non-selective cyclooxygenase inhibitor, meaning that it blocks both the COX-1 and COX-2 enzymes within our body. These enzymes are normally responsible for the production of prostaglandins, so by blocking them, it's able to mitigate the amount of prostaglandins that are released, thus reducing pain, fever, and inflammation. And that's a key differentiation between acetaminophen and ibuprofen in that ibuprofen does have local anti-inflammatory properties. Ibuprofen also works synergistically with acetaminophen. So while acetaminophen works only within the central nervous system and ibuprofen is able to exert peripheral anti-inflammatory effects and central analgesic and antipyretic effects, the net result of both of these medications when combined is greater than if we were just to use one medication when treating a pediatric patient experiencing a fever. The dose of ibuprofen is 10 milligrams per kilogram as needed every 4 to 6 hours. And it should be noted that ibuprofen is not used in pediatric patients less than 6 months of age. Again, it's also important that prior to administration, we ask caregivers about whether or not they've already administered ibuprofen prior to us giving this medication, as we don't want to exceed the daily dose, which is around 40 milligrams per kilogram per day. Prior to giving the medication, we'd also want to take in a couple additional precautions, such as, does the patient have any hypersensitivity to NSAIDs? Is there any evidence of renal impairment or dehydration? Is there any history or current illness of gastrointestinal bleeding or irritation? As ibuprofen's blockade of COX-1 enzymes within our GI system can lead to increased bleeding. So we generally are going to avoid ibuprofen in patients that we suspect may require surgery. So ibuprofen can be used safely in pediatric patients with discomfort secondary to a fever. It works synergistically with acetaminophen and can serve as a valuable tool to managing our pediatric patients in pain. With acetaminophen and ibuprofen, because they are both administered orally, prior to administration, we would need to ensure that the patient has an intact airway through our assessment and is able to swallow the medication without difficulty to prevent and protect against aspiration. Nitrous oxide is also a medication that is found on many BLS local protocols throughout our nation. However, according to the National Association of State EMS officials, nitrous oxide is not considered a BLS medication. So, in places where EMT basics are administering nitrous oxide, that is a local protocol adaptation that the medical director and the EMS agency have approved and provided training to providers to administer this medication. Inhaled analgesic that is used widely across pre-hospital medicine. It's able to provide effective pain relief for patients in mild to moderate pain and can help with short, painful procedures such as splinting or burn care. So, if you are at an agency that does utilize nitrous oxide, please be sure to be aware of this medication's mechanism of action and its contraindications, as well as your process on how to safely administer nitrous oxide. Thank you for joining me here at CE Solutions for Pain Management in Pediatric Patients, Volume 1. And remember that when assessing a pediatric patient in pain, we start by understanding the child's developmental age, whether they're preverbal or verbal. And that helps guide our decision making on how to best assess and address their pain levels. When it comes to assessment, we should document our pain assessment as it's a vital sign and reassess the pain assessment continuously. We should prioritize non pharmaceutical pain management modalities first, such as splinting, distraction techniques, the use of a caregiver, and physical touch or providing a care item to our patients, and utilize pharmaceutical pain management in conjunction with our non pharmaceutical treatment options.